Hello everyone, very good evening to all. This is Dr. Abirami, your faculty for Physiology. Yes, students are joining in the class. Yeah, we'll start off with a small introduction, not to physiology, but to your preparation itself. This is the story of John Carpenter. I hope all of you are aware of this program called Millennial. It was telecast in all languages. I think in Hindi it was Kaun Banega Crorepati by Amitabh Bachchan. Yes, there are a series of questions in the program. You answer every question, you'll have a chance to win $1 million in the last question. This man, John Carpenter, he was the first person to win $1 million in this program. And there are some lifelines in the program, like you can call a friend and you can ask for the answer, or of the 4 options they will remove 2 options, 50-50. This man did not use any of the options until the last question, and on the last question he said, I want to call my father. So it's a live program telecasted, everybody is watching, the whole world is watching. He is calling his dad and he's saying, in the next question I'm going to win $1 million. He kept the phone, he gave the right answer, and he won $1 million. See, this much of self-confidence. How will you get this much of self-confidence even without knowing the right answer key? He is saying that I'm going to win $1 million. That is because he has clarity in the subject. He knows that it is 100% the right answer. That's how he's got this much of confidence. And when the host has asked him, why did you do like this? He said, if the program is telecasted, the whole world will come to know that I have $1 million, and after that only my father will come to know. That's why I called my father and I told him this. So now he is the first person to know that I have won this $1 million. After that only everybody is going to know. Similarly, self-confidence in your exams also. How will you get self-confidence in your exams? Where will you search for self-confidence? Usually, yes, in an Instagram reel where somebody is climbing on a mountain and there's a music from behind, or in a WhatsApp forward message, or in a class where somebody is saying that you can do it. Nothing can give you self-confidence except you sit and learn your subjects. You have enough clarity in your subject. You know that this is the right answer for the question. That is what is going to give you confidence. If you know the correct answer for first 10 questions in your exam, that will give you the confidence for the remaining of the paper. If you don't know the answer for first 10 questions, you will lose your confidence in the entire paper. So always keep in mind, learning the subjects and getting clarity in the concepts is the best way to gain self-confidence. You don't waste time searching for confidence anywhere else. It is just on attending classes properly, taking notes properly, and revising the notes thoroughly so that you are able to gain enough confidence by the time you go for your exams. That was about John Carpenter. And over to physiology. The importance of learning physiology. Physiology is a basic subject, but still, only if you know the concepts in physiology, you will be able to correlate this in medicine, pathology, and pharmacology. That is the essence of learning physiology. Basic subjects, especially anatomy and physiology, only if you are thorough with your basic subjects, you will be able to do well in your clinical subjects as well. For example, there is a question in pharmacology on treatment of diabetes mellitus, a drug related to diabetes mellitus. How will you answer the question without knowing what is diabetes mellitus, what is insulin, what are the actions of insulin, what is insulin doing to glucose? All this is taught to you in physiology. Without knowing all this, you can never touch these type of questions. So please understand that physiology forms a very strong basis for your clinical subjects, especially medicine, pathology, and pharmacology. Everyone has a dream, but not everyone has a plan. You can see all these sperms are going to the ovum. But look at that little one in the center with a bouquet in its hand. All of them are doing hard work, but only this one is doing smart work. Hard work is not important when it comes to a competitive exam. Smart work is what is more important, because it is not possible to read everything by the time your exams will come. When you want to read everything, that is hard work. It's not important. What is that smart work that you can do? Give more importance for high yield topics, repeated topics, PYQs. Without knowing the answer for PYQs, previous year questions, and without revising the previous year topics, it is very, very difficult to get through your exams. The first rule is that previous year questions and topics, give more importance for them. Hebb's rule. What is Hebb's rule in physiology? A synapse. What is a synapse? The junction between two neurons is called as a synapse. The place where two neurons meet is called as a synapse. Everything is stored inside synapses. All the faces that you see, for example, you look at my face, it will be stored in a synapse. Next time you look at my face in a photo, you'll be able to recognize my face because it collects it from that synapse. You learn anatomy, physiology, your subjects, all this is stored inside synapses. Yes, we are all connected in the Telegram group. So I think is Dr. Mithilesh Kumar has messaged. Very good evening, doctor. I think the audio visuals are fine, Dr. Mithilesh. So if there's any trouble, kindly let me know in the group. Yes, thank you. So what is Hebb's rule? You have the ability to strengthen your synapse or weaken your synapse. That is called Hebb's rule. How do you strengthen your synapse? For example, if you are in love with someone, you keep thinking of that girl or boy again and again. Every time you think of that person, your brain is converting short-term memories of that person into long-term memories. Hippocampus in your brain will do this. If the class is boring, you think of that girl. Or when you listen to a nice song, you think of that girl. Every time you think of that person, your brain is converting it into long-term memory. That's why even after a breakup, we are not able to forget the person because your brain has already converted their memories into long-term. Yes, Dr. Ruchira, welcome, doctor. Similarly, how do you convert short-term memories of your subjects into long-term memories? Like how you think of that person again and again, you recollect your subjects again and again. At least 3 times if you revise your subjects, your brain will be able to convert short-term memories of the subject into long-term memories. If you just read once and you leave it, you go to the exam, you will not be able to recollect anything because all this would have faded away as short-term memory. At least you revise 3 times only, your brain can convert it into long-term memory. So you can do this especially for subjects that you don't like. Subjects that we like, automatically we will learn. If there's a subject that you don't like, you revise it again and again. Even if you don't like the subject, automatically your brain will convert short-term memories of the subject into long-term memories. That is what is called Hebb's rule. The magic of revising your subjects again and again. Good evening, Dr. Shameha. Good evening, doctor. See, the other tip that students usually, the toppers usually tell us is practicing a daily routine. From day 1 onwards, try to solve as many questions as possible. What is the use of solving questions every day? Especially in an online format, you should be able to solve your questions. So when you keep on looking at online question, ruling out the distractor, and getting into the right answer, submitting the right answer, all this itself is an art. It comes by practice only. If you practice questions every day, at least 25 questions you have to practice every day in an online mode, your speed will increase in your exam. Time management will be very, very efficient in your exams. So that is about practicing a daily routine. And the other essence of practicing a daily routine. Yes, all of you please look at this question. Good evening, Dr. G. Look at this question. 2024. What is the answer for this question? Yes, you can post in the Telegram group. What is the answer for this question? Yes, Dr. Mithilesh, Ruchira, Shamiha. A, B, C or D? What is the answer? Okay, if you say it is option A, you see 2024 in option A. That is right. If you say option B, that's also right because option B also has 2 zeros and 2 fours. Option C, yes, that also has 2024. Option D also has 20 and 2 fours. Yes, Dr. Agarwal says option A. It depends on the person. Yes, A, B, somebody else is saying option B. Good, that's what I want. So if you have a question like this in the exam, what is the best thing that you can do? Do not waste much of the time in questions like this. You leave it and go to the next question. If you sit and all of the above, Vedasri, good daughter. If you sit and think of the answer for a question like this and you waste 10 or 15 minutes in the same question, you will not have time to answer the other questions. So the essence here is you should know how much time to spend for a question and how much time not to waste on a question. If you have a question where you're very sure that it is not option A, it is not option B, I'm very sure it's either C or D. Only two options you have ruled out. Now you should not leave this question because 50-50 chance of getting it right. So if you have a question like this, try to spend some more time and solve the question because you have 50-50 chance of getting it right. How will you check all these strategies? It comes by practice only. You keep on solving questions every day. Just before your exam, you will come to know what is your strategy in attending the exams. How much time I should spend for a question. What is my time management? All this cannot happen on one day on the final exams. So please have the habit of solving questions every day. Very, very important. Most important step in PG preparation is solving questions every day. Yes, over to yes, doctor has a doubt. Do we have to by heart the question daily or solve? Never, never by heart the question. It is of no use because question will never be asked again. One question is never repeated again. The topic might be repeated, the concept might be repeated. Never do this mistake of by hearting the answers. That will never work for you. You look at the question, read through the answers, get the right answer, read the explanation. That is more important. Reading the explanation for every question is very important because when you go through the explanations, you are revising the same topic again. So if there's a question from the same topic again, you'll be able to answer. Never by heart the answers. Yes. Let's start off with the first one. General physiology. Let's start off with general physiology. General physiology is a very common topic where we're going to learn the basis of physiology. After that, we'll start off with nerve physiology. Yes, can we start? Yes, we have few doctors who are very active in the group. Dr. Vidhi, Dr. LK, Dr. Ruchira, Agarwal, Samiha, Jigyasa Singh. Yes, thank you all of you. Just stay active till the end of the class. We'll start off with this. You can't make an omelette without breaking a few eggs. If you keep crying about the eggs being broken, you will never taste a good omelette. So you should know where you should waste your energy and all your emotions and where you should not do this. Don't always keep worrying about the eggs being broken. It's okay, but still you are there to taste a beautiful omelette. General physiology. Let's start off with basics in general physiology. Okay, Dr. Samiha has a doubt. If there is extra points in explanation, do we have to write it down? Exactly, doctor. You have to bookmark the questions which you have done it wrong, and you keep adding extra explanations, especially for the questions where you have gone wrong. Okay, so when we start off this session, I'm sure that you won't be able to write everything what I'm teaching in the class. It's not possible to write everything and draw everything. So what we will do, I will complete the class. At the end of the class, let me share the annotated PDF in the group. I'll share it with you. So you can go through this annotated PDF. Whatever I'm writing, my class written notes, I'll share it with you. So the entire thing you can go through after the class. So just spend time listening to the class. Don't spend time writing. I'll share you the soft copy of the notes. Yes, there's another doubt. Ma'am, for revising the subject, every time do we have to do a notes and then solve the question, or only MCQ practice is enough? Revising the subject is the first step, doctor. For example, you start with physiology. I'm teaching physiology now. You listen to the class, you take notes, or if I'm sharing you the notes, you keep it safe. You revise the notes once. Then you solve the questions in general physiology. Then we'll do nerve physiology. You read nerve physiology, solve questions in nerve physiology. And at least once in a week, try to solve one grand test paper. Okay? Yes, that is how we go around. Is that okay for all of you? You need not write, you just listen to the class. At the end of today's class, once general physiology and nerve physiology is over, I'll share you the annotated PDF, the soft copy. You can just go through that. Is that okay for all of you? If you can just give me a thumbs up in the group. So that you can spend your time listening to the class rather than drawing and writing. Exactly. You can revise from handwritten notes of DBMCI. Yes, that is what I'm going to take now. Whatever class I'm taking, that is what is there in the handwritten notes also. Thank you, Dr. Ruchira. Yes. Okay. Good. We'll start off. Good. Listen. First, tell me, whose father is this? So many thumbs up I'm seeing. Thank you. Thank you so much. Such an active class. Yes. Tell me, whose father is this? Can anybody tell me whose father is this? If I'm asking you the question, this is not my father. Whose father is this? Yes, father of physiology. Who's called the father of physiology? Claude Bernard is called father of physiology because of his important contribution, milieu interior. He coined this word milieu interior. What is milieu interior? The internal environment of the body is called milieu interior. Which is the internal environment of the body? All the cells are embedded in the extracellular fluid. So let me draw few cells for you. If these are all the cells, all these cells are embedded in the ECF, the extracellular fluid. So this extracellular fluid is what is called the milieu interior. The background space is the extracellular fluid. All cells are embedded inside the extracellular fluid only. So the internal environment of the body is the extracellular fluid. So he gave this word milieu interior to extracellular fluid. So Claude Bernard coined this word milieu interior for extracellular fluid. Another person, W.B. Cannon, Walter Bradford Cannon. What is the contribution of Walter Bradford Cannon? He coined this word homeostasis. What is homeostasis? Maintaining the constancy of internal environment of the body. Claude Bernard said ECF is the internal environment. Now Cannon says you have to maintain the constancy of this internal environment. How do we maintain the constancy of this internal environment? We have control systems to do this for us. What are the different types of control systems? There are two types of control system: feedback control system and feed forward control systems. What is feedback control system? When there is a stimulus and a response, that is feedback. What is feed forward control system? There is no actual stimulus, but still if there is a response, that is feed forward control system. In feed forward, there is no actual stimulus. Without an actual stimulus, how will you get a response? We will see. Even without an actual stimulus, sometimes you can get a response. That is called feed forward. If there is a stimulus and a response, feedback. If there is no actual stimulus, still there is a response. This is feed forward. What are the types of feedback systems? Positive feedback and negative feedback. Let's discuss all this in detail. What is positive and negative feedback? Positive feedback is when there is a stimulus and a response. Stimulus increases the response. Response increases the stimulus. One is enhancing the effect of the other. One is increasing the other. This is called positive feedback. Stimulus increases the response. Response increases the stimulus. What are the examples for positive feedback? The mnemonic is CLAPS. C L A CLAPS, claps. C for clotting. C for clotting mechanism. What happens in clotting mechanism? If there is any injury to the blood vessel, the injured blood vessel will attract platelets. These platelets will produce chemical mediators. That will again attract platelets. That will again produce chemical mediators. This is a positive feedback cycle. It will keep on happening. Another C for calcium induced calcium release. C for calcium. This we will learn in the cardiovascular system. In heart fibers, you will understand this. L for LH surge. When does LH surge take place? Yes, just before ovulation in the menstrual cycle. LH means luteinizing hormone. LH increases estrogen. Estrogen increases LH. Again, LH increases estrogen. Estrogen increases LH. This is the positive feedback. Just before ovulation, there is LH surge. Another L for lactation reflex. What happens in lactation reflex? Lactation reflex is at the time of lactation, breastfeeding the baby. If this is the mother and the baby, when the baby sucks milk, the love of the mother increases and mother produces love hormone. Which is the love hormone? Oxytocin. More the oxytocin, oxytocin can cause contraction of the breast cells. When breast cells contract, more the baby, more the milk is ejected, more the milk is ejected, more the baby sucks. More the baby sucks, again love of the mother increases, more oxytocin, more contraction of the breast tissue, more milk is ejected. That's why in a natural method of breastfeeding, only if the mother is willing to feed the baby, the love of the mother can increase, producing more oxytocin, and thereby the baby sucks more milk. Again, love of the mother increases, more milk is ejected. That's why it is called the milk ejection reflex. That is the lactation reflex or milk ejection reflex. A for action potential, that we will do in nerve physiology. Entry of one sodium will increase the entry of many sodium, that we will do in nerve physiology. P for parturition reflex, otherwise called Ferguson's reflex. What is parturition or Ferguson's reflex? Parturition means at the time of delivery of the baby. This is the mother and the uterus. When there is contraction of the uterus, the baby descends down. More the baby descends down, love of the mother increases and mother produces love hormone oxytocin. More the oxytocin, it causes more contraction of the uterus. More the contraction of the uterus, baby descends down. Again, love of the mother increases, more oxytocin, more contraction. That is why even if you want to deliver a baby by normal labor, the mother willingness is very important. If the mother is not willing to push, have you seen in movies like Three Idiots, people stand around and they say push, push. Only if the mother is willing to push, the baby can be delivered. So you need oxytocin for that. If the mother is not willing or the mother becomes unconscious, you have to infuse oxytocin or you have to go for a cesarean section. So wherever there is love of the mother for the baby, there is oxytocin, and that is why oxytocin is called as the love hormone. Not only love of the mother for the baby. Wherever there is love, there is oxytocin. There was a Russian study where scientists, they conducted study on 100 couples, and they measured the levels of oxytocin in 100 couples during different stages of life. Exactly before marriage, when they measured the levels, oxytocin levels were very high. Not yet married, no, so the level was very high only. Just after marriage, still the levels were high, because just now they got married, still there is love. After 1 year, the levels are decreasing. After 2 years, after 5 years, and then oxytocin vanishes. So they concluded that when people are actively in love, oxytocin levels are increasing. So if there is anybody who is actively in love in the class, you can go to the lab and check your oxytocin levels. It will be high. Or if you want to check your partner's love also, you take them to the lab and check for oxytocin levels. It will be high. It should be high. So that's why it is called the love hormone. Love hormone plays a very important role in lactation reflex and parturition reflex, otherwise called Fergusson's reflex. S for shock. What happens in shock? When body is in shock, it means heart is not pumping properly. Cardiac output decreases. When cardiac output decreases, BP decreases. When BP decreases, venous return decreases. When venous return decreases, again cardiac output decreases. One is enhancing the effect of the other. If you don't intervene and treat, the patient will die from shock. So these are the examples for positive feedback. What about negative feedback? Negative feedback means stimulus and the response act in opposite directions. For example, whenever there is a decrease in T3, T4 levels, thyroid hormone levels are decreasing. As a negative feedback, TSH level increases. When there is a fall in T3, T4, TSH rises. Thyroid stimulating hormone increases. So stimulus is decrease in T3, T4, but response is increase in TSH. This is example for negative feedback system. What are the examples? All hormones except LH and oxytocin, because LH and oxytocin plays role in positive feedback. So all endocrine hormones negative feedback except LH and oxytocin, which follows positive feedback. BP regulation by baroreceptors. Blood pressure regulation by baroreceptors. Because whenever there is an increase in BP, baroreceptors will decrease the BP. And increase stimulus is increase in BP, but the response is decrease in BP. Opposite directions. So BP regulation by baroreceptor is also an example for negative feedback system. So all these are examples for positive and negative feedback control systems. We also have feed forward control system. What is feed forward control system? Sometimes there is no actual stimulus, but still there is a response. This is feed forward control system. There is no actual stimulus. Without an actual stimulus, how will you get a response? For every response, there is an actual stimulus. Let's see what are they. For example, in gastric acid secretion, what is the actual stimulus for gastric acid secretion when you eat food? Food in the stomach only is the actual stimulus for gastric acid secretion. Sometimes even without eating food, just thinking about the food, or I bring a plate of biryani near your nose, the smell of the food, or I show you the video of making of a nice cheese pizza with some toppings and all, you look at that video itself, your gastric acid secretion will increase. So not necessarily food. Actually, the stimulus is food only, but even without eating food, thinking of the food, smell of the food, or looking at the food itself, if it increases the response, this is called the cephalic phase of gastric acid secretion. This is an example for feed forward control system. The other one, anticipatory tachycardia, another example for feed forward. When you run on a treadmill, there is tachycardia. Tachycardia means heart rate increases. Sometimes, even before running on a treadmill, your heart rate can increase. When will this happen? For example, you take your grandparents near the treadmill and you tell them, for the next 1 hour, you have to run on full speed on the treadmill. They will have palpitations. Even without running on the treadmill, they will have palpitations. That is called anticipatory tachycardia. Even without running on the treadmill, your heart rate can increase. Anticipatory tachycardia. Third example, anticipatory shivering by the posterior hypothalamus. Whenever you enter into a cold room, your body will begin to shiver. When you shiver, all muscles are contracting. When all muscles are contracting, heat is produced. That's why we shiver. When it is very cold, why do you shiver? You shiver to produce heat. So even before your body temperature could fall, when you enter into a cold room itself, you begin to shiver. Actual stimulus for shivering is your body temperature could fall. But even before your body temperature could fall, when you enter into a cold room itself, you begin to shiver. So anticipatory shivering by posterior hypothalamus. Another example, motor correction by the cerebellum. Cerebellum plays an important role in motor correction, correcting your motor activities. Just imagine when you're walking, you miss your steps. When you miss your steps, you are about to fall, but you don't fall because your cerebellum will give you a correction. Every time you miss your step, are you falling? No, somehow we balance and we come into position. That is motor correction by the cerebellum. How cerebellum gives you a motor correction. Even before you could fall, it is giving you a motor correction. Number 5, insulin release. Anticipatory insulin release. What is the stimulus for insulin release? Glucose only. When your blood glucose rises, that is the major stimulus for insulin release. But sometimes, even before actually your blood glucose could rise, when you eat nice carbohydrate rich food itself, your pancreas will detect he has eaten nice carbohydrate rich food. All this is going to be converted into blood glucose. So let me start producing insulin. So when you eat carbohydrate food itself, your pancreas will detect this and it will start releasing insulin. Exactly, Dr. Vipun. So all these are even without an actual stimulus. There is no actual stimulus, but still there is a response. This is called feed-forward control systems. So there are feedback control systems and feed-forward control systems. For a negative feedback system, this is for negative feedback system. How do you calculate gain of the system? How to calculate gain of a negative feedback system? The formula for gain is equal to correction divided by error. How do you remember this? You would have done plenty of errors in your life. Of all the errors, how much ever you have corrected is a gain for you. So put your errors below. Of all the errors, how much ever correction you have done is a gain for you. So gain is equal to correction divided by error. Let's say a system has error of 0. It means it has not done any mistake at all. Error is 0. Anything divided by 0, correction by 0. Anything divided by 0 is infinity. Now, when the error is 0, no mistake at all. So infinity gain. Gain becomes infinite when error becomes 0. Which is that only system where error is 0, therefore gain becomes infinity. This is renal regulation of blood pressure. When your kidneys are regulating blood pressure, they leave no error. Since there is no error, gain becomes infinity. That was a repeat question. One system which has an infinite gain, renal regulation of blood pressure. Yes, now can you try this question and let me know the answer? Good, Dr. Harman. Can you all try this question and let me know the answer? What is the answer? Yes. Yes, how do you solve this? On changing position, there is a drop in 10 millimeter mercury. So the BP falls by 10 millimeter of mercury. Immediately, he recovers by 8. So how, there is a drop in 10 millimeter of mercury. 10 millimeter pressure has fallen, but recovered by exactly. Dr. Agarwal Aditi, very good. B. Sanjana, very good. I'll tell you how you got this answer of 4 is the answer. Very good. There is a drop in 10 millimeter of mercury. Recovery means you have corrected 8 millimeter of mercury. The baroreceptors have recovered. Recovered means corrected 8 millimeter of mercury. Leaving behind an error of 2 millimeter of mercury. Leaving behind means this is not corrected. So this is correction by error 8 by 2, which is 4. So we get this answer as 4. Excellent, all of you. LK, Preeti, Mithilesh and Ruchira. Very good. The answer is 4. So if the system has corrected something, that is correction. If it has not corrected something, that is the error. So 8 divided by 2 is 4. 4 is the answer to this question. Over to body fluid compartments. What are the body fluid compartments? We have solid compartment and total body water compartment. So on top, what you see in yellow color is the solid compartment, the solid tissue, and below what we see in green is the total body water. So these are the two compartments inside the body. We will see how these compartments are divided. In any adult female, let's take any female, there is 55% of total body water. In any adult male, 60% total body water. In babies, infants, 75% total body water. So we see that females have little less compartment of water, more of solids, because females have breast tissue that adds on to the fat compartment. Solid tissue is breast tissue, fat tissue, that's a solid compartment. So that's why solid is more in females. Why infants have 75% of total body water? Why they have so much of water? Because the infant's kidneys are not well developed. So these kidneys cannot concentrate urine. Since they cannot concentrate urine, they will be losing more water. That's why you keep changing diapers for children. Since they are losing more water, by nature, God has given them more water. You're going to lose more water, so you keep more water. By nature itself, until their kidneys are developed, they have plenty of water. Once their kidneys begin to develop, then this water compartment will decrease. For any example, prototype, we usually take an adult male of 70 kg. An adult male of 70 kg, we'll take that alone and we'll discuss. So here I'll write any adult male of 70 kg who has 60% of total body water. How is this 60% total body water divided? So this is divided into two compartments. So as you know, one compartment is inside the cell, other compartment is outside the cell. So they are ECF and ICF. This is divided into 1/3 of ECF and 2/3 of ICF. So 1/3 goes to the extracellular fluid and 2/3 into the intracellular fluid. We generally think that ECF is more because it is outside, but it is not like that. Body is made up of millions and millions of cells very closely packed like this. So you can see cells only are more. Outside space is very less. Since so many cells are there, the intracellular compartment only is more. It is almost 2/3 of the total body water. ICF only is more. In percentage, if you divide, 1/3 of 60% is 20%, 2/3 of 60% is 40%. And exactly if you want this in a value of liters, you can calculate how much is 60% of 70 kg. How much is 60% of 70 kg? Even you calculate, yes, it comes up to 42 liters. 60% of 70 kg is 42 liters. So how much is the total body water in an adult male of 70 kg? 42 liter. And how is this 42 liter divided into? If you divide it as 40% and 20%, or if you divide it as 2/3 and 1/3, so this will give you, yes, exactly, this will give you around 28 liters and 14 liter. 2/3 of 42 liter is 28 liters. 1/3 of 42 liter is 14 liters. This is how it is divided. And again, if you want to divide this ECF compartment, there are two compartments in the extracellular fluid. So what do you have outside the cells? Outside the cells, we have just the space. The space is called as interstitium. And outside the cells, we have plasma. You just have the space and the plasma. The space is the interstitium, and outside the cell there are blood vessels. Blood vessels contain plasma. So ECF is again divided into interstitium and plasma. 20% is divided as 15% and 5%, or 14 liter is divided into 10 liter and 4 liter. This is how total body water is distributed inside our body. Now, all this value in liter is only for 70 kg adult male. If it is an 80 kg, you have to calculate 60% of 80 kg. For 70 kg adult male, 42 liter. According to the weight, it will change. So be careful there. How will you measure all these body fluid compartments? The method is called indicator dye dilution technique. Indicator dye dilution technique. You use specific dyes for specific compartments. For example, there is a dye, and this dye has the property of occupying the total body water compartment. I inject this dye into a patient. This dye will occupy total body water compartment. If I measure the volume of distribution of that dye, it would have occupied total body water. So that will give me how much is my total body water. Similarly, if there is a dye which occupies only the ECF, you inject this dye and you measure the volume of distribution. That will give me how much is the ECF compartment. So similarly, we can measure the body fluid compartments by giving dyes. That is called indicator dye dilution technique. Now, what are the dyes that we use? To measure total body water, I can use something which is like water itself. I can use heavy water. So total body water, this can be measured by using heavy water, which is called deuterium, tritium, or dyes like antipyrine, aminopyrine, antipyrine, and aminopyrine. For the measurement of ECF, extracellular fluid, what are the dyes that we use for measuring extracellular fluid? Which is the major ion in ECF? Sodium. So I can use something like sodium. Sodium thiocyanate. Sodium thiosulfate, or radioactive sodium. Radioactive sodium. Or I can use inulin, mannitol, sucrose. All this when injected will occupy only the ECF compartment. So you can use all this. That's why ECF is called inulin compartment, or the mannitol space, inulin space, mannitol space, sucrose space. All these are other names for ECF. There is no specific dye for measuring ICF. There is no special technique. You can't measure ICF directly. If you know total body water and ECF, from there you can measure ICF. Otherwise, you can't measure ICF. ECF is again divided into interstitium and plasma. How is this divided into interstitium and plasma? As 15% and 5%. How will you measure interstitium? There is no specific agent for interstitium. But for plasma, I have special techniques. I have special dyes. Plasma has plasma proteins in them. What are the plasma proteins? Albumin is a plasma protein. So I can use albumin, or radioactive iodine 125, or I can use dye called Evans blue. So for ICF and interstitium, there are no specific dyes. If you know the other compartments, you can measure them. Apart from this, there is another special compartment in ECF called transcellular compartment. What is transcellular compartment? The fluid occupying cavities like pericardial fluid, pleural fluid, synovial fluid, CSF space, peritoneal fluid. All this together itself is only 1 liter. It comes up to only 1 liter. So sometimes transcellular is a special compartment, or it is included in ECF also. So another negligible compartment, transcellular compartment. This is only 1 liter. And please explain interstitium and plasma again. Yes, ECF is divided into interstitium and plasma. We'll remove this transcellular compartment. It's confusing. Okay, as of now, ECF, outside the cells, you have interstitium. The space is interstitium and the blood contains plasma in it. So ECF includes interstitium and the plasma. This 20% ECF is divided into 15% and 5%. 20 is divided as 15 and 5. 14 liter will be divided into 10 liter and 4 liter. This is how ECF is divided. How do you measure them? For measuring ECF, sodium is the major ion in ECF. So we can use sodium thiosulfate, sodium thiocyanate, radioactive sodium, inulin, sucrose and mannitol for measuring ECF. For measuring plasma, plasma contains plasma protein albumin. So I can use just albumin itself for measuring plasma, or radioactive iodine 125, or dyes such as Evans blue. So all these are used to measure plasma compartment. You can't measure interstitium directly. If you know ECF and plasma, from there you can calculate the interstitium. Clear, Dr. Archie Agarwal? Yes. So this is called the indicator dye dilution technique for the measurement of different body fluid compartments. Which is the major cation in ECF? Extracellular fluid, which is the major cation, intracellular fluid, which is the major cation? Yes, can you type the answer for the question? What is the answer for this question? Can you try the answer for this question? Is anybody? What is the answer for the question? Magnesium. Very good. Awesome. Very good. Magnesium. Very good, doctors. So nobody is doing silly mistake. Good. So I'll just tell you the compartments. ICF and ECF. The major cation in extracellular fluid is sodium. The major cation in intracellular fluid is potassium. But actually the answer for this question is potassium. Since potassium is not there, we go for magnesium. So the second major cation in ICF is magnesium. So first it's potassium followed by magnesium. So the answer to this question is magnesium. What about anions? The major anion in ECF is chloride. Major anion in ICF is proteins and phosphates. This is about the major cation and anion composition. Daily input and output of water every day. What is the intake of water? We drink water. How much water you should drink every day? You should drink at least 2100 ml of water every day. From metabolism, another 200 ml is released. So total intake is 2300 ml. What is the output? How do you lose water? First we have insensible water loss. Insensible means you cannot see or you cannot measure. You can't sense that through skin by the process of radiation, convection, all that, 350 ml. From lung in the form of water vapor. When you breathe, you can't see water vapor, that is 350 ml. So insensible water loss is 350 plus 350, 700 ml. What are the other water losses from the body? In sweat, approximately 100 ml. In feces, approximately 100 ml. In urine, around 1400 ml. Total output is 2300. You can see total intake is 2300. Net output is also 2300. Almost both are same. Both should actually match for each other. The input and output should match with each other. That is why you should drink at least 2 liters of water every day. If you drink less than 2 liters, your output will be more than the input. You will have water imbalance related diseases. But there was one question from this. How much is the total insensible water loss in the body? There was a repeat question on this. Yes, around 700 ml is the insensible water loss from the body. So exactly this was the question. Just go through this question. See if you're able to get the answer. A staff nurse wants to determine the quantity of IV fluids. How much of insensible water loss per day she will account for? Actually, the answer is 700 ml. Since 700 ml is not there, we go for 500 to 600 ml. Or it's around 700 ml. Exactly, it is 700 ml. The concept of osmolarity and osmolality. Let's understand osmolarity and osmolality. It's almost nearly an hour you are attending the class. So let's just break for 5 minutes. Yes, have a break, have some tea or coffee. Just 5 minutes, let's break and we'll continue after 5 minutes. Yes, just a 5-minute break and then we'll continue. Meanwhile, if you have any doubts or any feedbacks, you can post it in the Telegram group. Yes, otherwise, let's have a short break. Thank you. Can we start again? Yes. Thank you, Dr. Vishnu. Okay, we're just starting again. Yeah, in the group also. I'll just post in the group also. We are starting now. Okay. The concept of osmolarity and osmolality. This is a very complicated topic, but let's try to learn it in a very simple way. First, understand few definitions here. 1 mole of any substance. Let's take 1 mole of any substance. Let's say this is 1 mole of any substance. I have 1 mole of any substance. I will listen carefully. I'm going to take 1 mole of any substance. I'll place it on the weighing machine. Now this weighing machine will give me a weight in grams. What is this weight? The weight of 1 mole of this substance, which is called molecular weight. So what is molecular weight? 1 mole of any substance you put on the weighing machine, it will give you molecular weight. So 1 mole is equal to molecular weight in grams. When you take 1 mole of sodium chloride and you place it on the weighing machine, let's say if this is 1 mole of sodium chloride, I'll put it on the weighing machine, sodium chloride on the weighing machine. This gives me a weight of 58.5 grams. So what is 58.5 grams? Weight of 1 mole, which is called molecular weight. So what is the molecular weight of sodium chloride? 58.5 grams. I'll take 1 mole of sodium chloride. I'll place it on the weighing machine. It is reading 58.5 grams. So 1 mole of sodium chloride, the weight is 58.5 grams. What is osmol now? Whenever I take 1 mole of any substance, let's say sodium chloride, if this is 1 liter of water, I'll dissolve 1 mole of sodium chloride in 1 liter of water. It will divide into 2 osmotically active particles. Sodium is an osmol, chloride is an osmol. There are 2 osmotically active particles. So 1 mole of sodium chloride, when it is outside the water, it is 1 mole of sodium chloride. But when I dissolve in 1 liter of water, it divides into 2 osmoles. So 1 mole of sodium chloride is equal to 2 osmoles. 1 mole of sodium chloride is equal to 2 osmoles. Let's do this for calcium chloride. Now this is calcium chloride. CaCl2. CaCl2. 1 calcium and 2 chloride. I'll take 1 mole of calcium chloride. I'll dissolve in 1 liter of water. Now how many osmoles are there? 1 calcium and 2 chloride. 3 osmoles are there. So how many osmotically active particles? 3. So 1 mole of calcium chloride, when you dissolve, it becomes 3 osmoles. Let's do this for sugars. Till now we saw salts. Sodium chloride, calcium chloride, all these are salts. When you dissolve salts in water, they will split into ions like this. But sugars, they don't split like this. Sugars, for example, dextrose, sucrose, glucose, any sugar if you take, 1 mole of any sugar, when you dissolve in 1 liter of water, let's say this is 1 mole of dextrose. When I put this in 1 liter of water, it will stay as 1 liter only. Sugars don't divide because there are no ions to divide. Sugars stay as such. Salts will divide, but sugars stay as such. 1 mole of dextrose will stay as 1 osmole only. Salts are dividing, but sugars, they don't divide. Dextrose, glucose, sucrose, all these are sugars. Now, how will you measure the plasma normal osmolarity? What is the formula to measure osmolarity? Osmolarity is measured by, osmolarity means what? Concentration of the ions. If I take so many ions and I put it into 1 liter of a solution, what is the concentration of all these ions? That is the concentration of the solution. So osmolarity means you add all the ions and you get the concentration. The formula is 2 times sodium plus 0.055 times glucose plus 0.36 times blood urea nitrogen. This is the formula. So if I want to calculate osmolarity of plasma, I should take all the substances in the plasma, not only glucose, sodium and blood urea nitrogen. I should take all the substances and I should measure. But for a practical purpose of doing in a formula, I cannot write sodium plus potassium plus calcium plus magnesium plus phosphate plus lactate plus etc. etc. I cannot frame a formula like this. That's not possible. So what we do, normal plasma osmolarity is around 300 milliosmoles per liter. Out of this, maximum contribution is by sodium, glucose, blood urea, nitrogen. They will contribute to almost 295. So if I calculate only sodium, glucose and urea itself, I will get the approximate osmolarity of the blood. So instead of calculating, sitting and writing all the ions, we use only 3. To make the formula simple, we use only 3. Sodium, glucose, blood urea, nitrogen. That's how the formula becomes like this. What is the calculated osmolarity? Listen to this problem. What is the not in YouTube. Yes, Dr. Pooja, it's there on YouTube also, I think. Is it not there? Yes, it's there, doctor. It's on the YouTube also. Please check. Now, can you calculate this? What is the calculated osmolarity of a 1 liter solution containing 1 millimole sodium chloride, 4 millimole potassium chloride and 2 millimoles of calcium chloride? So what are they doing? They are connecting, they are placing all these salts into 1 liter of water. Sodium chloride, potassium chloride, calcium chloride, and they are asking you to calculate the osmolarity in milliosmoles per liter. So osmolarity is equal to number of osmoles per liter. So the formula for osmolarity is, if I want the osmolarity of this solution, I should calculate how many osmoles are there. Now there are 3 osmoles. So the osmolarity of this solution is 3 osmoles per liter. Now there are only 2 osmoles. Now the osmolarity of this solution is 2 osmoles per liter. So similarly, you just have to calculate the number of osmoles. Let's see what is all there in the solution. 1 millimole sodium chloride. Sodium chloride, when you dissolve sodium chloride in water, it will split into sodium and chloride, 2 osmoles. So 1 millimole of sodium chloride will divide into 2. 2 into 1 is 2 milliosmol. Now let's take potassium chloride, KCl. I'll dissolve potassium chloride in 1 liter of water. So 4 millimoles of potassium chloride, KCl. 2 osmoles are there. It will divide into 2. 4 into 2 is 8 milliosmoles. Calcium chloride. Now this is calcium chloride. CaCl2. I will dissolve in 1 liter of water. CaCl2. Calcium and 2 chloride. So 2 millimole of calcium chloride will divide into 3 osmoles. 2 into 3 is 6. So now when you add all this, 2 plus 8 plus 6 is 16 milliosmoles. So the answer to this question is 16 milliosmoles. You just have to add how many ever osmoles are there. If it is sodium chloride, 2. Potassium chloride, 2. Calcium chloride, it is 3. So this is how we solve questions like this. Yes, this one can you solve? What is the answer for this? Exactly, Dr. Mithilesh. Very good. Now, what is the answer for this? Which of the following would be hyperosmotic to 1 millimole sodium chloride? First, you calculate 1 millimole of sodium chloride will divide into 2. 2 into 1 is 2 milliosmol. So the osmolarity of 1 millimole sodium chloride is 2 milliosmol. Compared to 2 milliosmol, which of this would be hypertonic? Excellent, Dr. Manasa. C. Very good. Which of hyperosmotic means which is more concentrated than 2 milliosmol. We'll calculate for each. 1 millimole sucrose will divide into, it's a sugar. 1 into 1 is 1 milliosmol. Glucose is also a sugar. 1 into 1 is 1 milliosmol. Calcium chloride, CaCl2, 3. So 1 into 3 is 3 milliosmol. 1.5 millimoles of glucose. Glucose is 1. Sugar. So it will stay as 1.5 milliosmoles. So out of all this, which is more concentrated than 2 milliosmol? Yes, it is 3 milliosmol. So the answer is calcium chloride, because 3 millimole is more concentrated than 2 milliosmoles. Very good, Dr. Vidhi and Dr. Vedashri, very good. So this is how you understand differences between millimoles and milliosmoles. Yes, the cell membrane. The composition of the cell membrane. The cell membrane, there are proteins, lipids and carbohydrates. 55% proteins, 40% lipids and 5% carbohydrates. And this model was proposed by Singer and Nicholson. It's a bilipid layer with proteins and carbohydrates embedded. The model was discovered by Singer and Nicholson. So normally we see that proteins are more than the lipids. Proteins are more, which is that only membrane where lipids are 80% and proteins are 20%. This is the myelin membrane. Myelin sheath is myelin is an insulator. It's made up of lipid and proteins, and myelin has 80% of lipids, more of lipids because it's an insulator, and only 20% of proteins. So only exception is myelin membrane, which has more of lipids and less of proteins. So what are all the proteins and lipids that are present? The proteins are integral proteins and peripheral proteins. What are the integral proteins? Integral means they are present within the membrane. Since they are present within the membrane, they will connect inside and outside of the cell. So they act as receptors, channels and carrier proteins. The peripheral proteins, especially on RBCs, red blood cells, to maintain the shape of the RBCs, we have spectrin, ankyrin and band 3. Dystrophin is present on muscle. It's a muscle protein. So if there is any defect in spectrin, ankyrin or band 3, shape of the RBC changes. This is called elliptocytosis or hereditary spherocytosis. Muscles. Any defects in dystrophin causes muscular dystrophy. There are Duchenne's dystrophy, Becker's dystrophy. All these are types of dystrophies, muscle dystrophy. Then we have phospholipids. What are the phospholipids present outside the cell membrane? Phosphatidylcholine, which is otherwise called lecithin, and sphingomyelin. Phosphatidylcholine is otherwise called lecithin and sphingomyelin. Lecithin and sphingomyelin play an important role in surfactant, a composition of surfactant, lecithin and sphingomyelin. Inside the cell membrane, phosphatidylserine, phosphatidylinositol, and phosphatidylglycerol. That is called cardiolipin. Phosphatidylglycerol is called cardiolipin. There are antibodies against the cardiolipin. This is called anti-cardiolipin antibodies. Anti-cardiolipin antibodies. And anti-cardiolipin antibodies, they are present in diseases like autoimmune diseases like SLE, systemic lupus erythematosus, SLE, or multiple abortion, or recurrent thrombus formation. So all these are disorders related to anti-cardiolipin antibodies. Together it is called antiphospholipid syndrome. Glycolipids. What are the glycolipids? Gangliosides, cerebrocytes. There are so many diseases related to this which you will learn in biochemistry. Cholesterol. Cholesterol helps to maintain the membrane fluidity. Membrane fluidity is maintained by cholesterol. So all these are the different proteins and lipids that are present on the cell membrane. Membrane transport mechanisms. What are the different types of cell membrane transport mechanisms? Overall, the cell membrane transport is divided into active transport and passive transport. We'll learn all of this with example, active transport and passive transport. Overall, it is active and passive transport. Let's say there is a mountain and you want to climb the mountain. Yes, Dr. Prashik or Shivendra. This slide is not given in my notes. Why? See, the notes might not exactly match, Doctor, the slide, because this is a live class that I'm taking. We have updated in the class also. So few of them might be added as updated to the classes alone. Okay, please follow that. Yes, we have Dr. Shivendra. Let's say Dr. Shivendra is here. He wants to climb a mountain. How will you climb a mountain? You will go from low to high. When you go from low to high, you are going against the concentration gradient. So this is against the concentration gradient. Yes, Shivendra, do you need energy for this? Yes, you need energy. Need energy. You have to climb actively. So this is called active transport, where you go against the concentration gradient and also you need energy. What is Shivendra's primary source of energy? He will break his own ATP and he is getting his source of energy. So all ATPases, they are example for primary active transport. If you break your own ATP and get it for energy, this is primary active transport. All ATPases, sodium, potassium ATPase, calcium ATPase, the hydrogen proton ATPase, proton pump, hydrogen potassium proton pump, all ATPases are example for primary active transport. Now, let's say there is Shivendra's friend who is already climbing the mountain. Now, Shivendra wants to climb the mountain, but he is very lazy to break his ATP. So, he is just climbing on top of his friend and both of them are climbing up. Now, it is not Shivendra's primary source of energy. He is using his friend's energy. Most of the time, the friend is sodium. Along with sodium, Secondarily, if a substance is transported, this is called secondary active transport along with sodium secondarily. So it's called secondary active transport. So along with sodium means, example, sodium iodide symporter in the thyroid gland, sodium iodide symporter, or SGLT, sodium glucose cotransporters, or NKCC, sodium potassium chloride transporter. All these sodium and another substance secondarily transported. There are two types of secondary active transport. If sodium and the substance go in same direction, this is called a symporter. So all of these are symporters. Sodium iodide symporter, sodium glucose cotransporter, NKCC, where sodium and the substance move in the same direction. There are also antiporters, where two substances move in opposite direction. Sodium moves inside, the other substance moves outside. This is called antiport or counter transporter. Antiport or counter transporter. Example, sodium calcium exchanger or sodium hydrogen exchanger. Sodium calcium exchanger, both will move in opposite direction. Similarly, sodium hydrogen exchanger. So this is about active type of transport. Two types, primary active is ATPase, secondary is along with sodium. Now passive type of transport. In passive type of transport, already Dr. Shivendra is on top of the hill. He just wants to come down. How will he come down? He will come along the gradient. This is not against, along the gradient. When you move along the gradient from high to low. Do you need energy for this? You can just lie down and like a sliding mode, you can simply come down. Yes, no need of energy. This is passive transport from high to low. What are the different types of passive transport? Simple diffusion. In simple diffusion, simply you lie down there and you just come down like a sliding board. Oxygen and carbon dioxide will use this. Nobody is going to carry you. You just come down like that. Oxygen and carbon dioxide will do simple diffusion. The other one is facilitated diffusion. In facilitated diffusion, somebody is going to facilitate your transport. Someone is going to help you in your transport. Who's going to help you? Let's say there is a bus on top. If the bus is going to carry him down, this is facilitated diffusion. There's a carrier protein which will carry you down. But the problem with the bus is, a bus can hold a maximum of 50 people. If Shivendra is the 51st member on the queue, there's no place for him because it has already reached the Tmax. Once it reaches the Tmax, it will get saturated. It can't be transported after that. It will stop. If the bus is full, you can't come down. If the transporter is over, you can't be transported. So Tmax and saturation are followed by facilitated diffusion. The other type of passive transport for water is osmosis. Osmosis is for movement of water. Water can move simply or water can use water channels, aquaporins. Water channels called aquaporins. So these are the different types of active and passive transport. Yes, again, I'll repeat again. Active transport is against the gradient, low to high. This needs energy. Primary active transport is ATPase. Secondary active transporters, two types. Symporter means sodium and the substance go in same direction. Example, sodium iodide symporter, sodium glucose cotransporter, SGLT. NKCC, sodium potassium, N for sodium, K for potassium, C for chloride, another C for chloride. Sodium potassium chloride transporter. If the substance and the sodium move in opposite directions, it is an antiport. Example, NCX and sodium hydrogen exchanger. They go in opposite direction. Sodium will move inside, calcium will move out here. In sodium hydrogen exchanger, sodium will move inside, hydrogen will move outside. Passive transport is along the gradient, high to low, no need of energy. Simple diffusion for oxygen and carbon dioxide transport. Facilitated diffusion. Facilitated means as a carrier protein. Example, GLUT transporter. Example for facilitated diffusion, GLUT, or urea transporter, UT. GLUT transporter, glucose transporter, or urea transporter, UT. The problem here is if the transport, it's like a bus. If the bus is full, you can't come down. If the transporter is over, it reaches a Tmax, then it gets saturated. Osmosis is for water. Water can be simply transported, or water can use water channels called aquaporins. These are the different types of active and passive transport. Yeah, clear, doctor? I can see your teeth there, Dr. Teeth. Yes, fine. Okay. The structure of sodium potassium ATPase pump. So I'll just draw the structure of the pump. It is present on the cell membrane. It has alpha subunit and a beta subunit. The sodium potassium ATPase pump has alpha and beta subunit. On the alpha subunit, inside the cell, there is binding site for 3 sodium, and outside the cell, there is binding site for 2 potassium. So what is the role of sodium potassium ATPase pump? This will send out 3 sodium in exchange for 2 potassium, which moves in. 3 sodium is sent out, 2 potassium moves in. So the stoichiometry is 3:2. 3 sodium goes out, 2 potassium moves in. There are hormones and drugs which act on this sodium potassium ATPase. For example, insulin increases the activity of sodium potassium ATPase. Insulin will increase the activity of sodium potassium ATPase. Thereby, what is the effect of this? If sodium potassium ATPase activity increases, more sodium goes out, more potassium comes inside. More the potassium moves into the cells, outside the cells potassium will decrease. So if you increase the activity of the pump, potassium is sent inside. More potassium is sent inside the cell. So outside the cells potassium decreases. What is that called? Hypokalemia. That is how insulin adverse reaction is hypokalemia. Insulin therapy can cause hypokalemia in patients. If you suddenly infuse plenty of insulin into the patient, when will you do this? In DKA patients, in diabetic ketoacidosis patients, when you rush insulin into the patient to bring down the blood glucose level, when you push insulin, on the other side, it will cause hypokalemia. So hypokalemia is an adverse effect of insulin therapy. The other drug, digitalis, used in the treatment of heart failure. Digitalis is a drug which inhibits sodium potassium ATPase pump. Insulin increases the activity of sodium potassium ATPase, whereas digitalis inhibits the activity of sodium potassium ATPase. So these are two different hormones and drugs which will increase and inhibit the activity of sodium potassium ATPase. Is over to the different types of vesicular transport. we have discussed about active transport and passive transport. There's a special type of transport called vesicular transport. Vesicular means how vesicles move the substances. This is called vesicular type of transport. In vesicular type of transport, the vesicles can bring the substance into the cell, which is called endocytosis, or the vesicles can push the substance out of the cell. This is called exocytosis, or it will do both. Endocytosis on one side, exocytosis on the other side. This is called transcytosis, based on how the vesicles are moving. First we have endocytosis. Endocytosis means how the vesicles are bringing the substance inside the cell. If it brings a solid substance inside the cell, this is called phagocytosis or cell eating. Solid substances, bacteria, virus, dust particles are engulfed by phagocytosis. If a liquid particle is engulfed, this is called pinocytosis. Pinocytosis is cell drinking liquid particles. Receptor mediated endocytosis. If a receptor is helping you in the transport, this is called receptor mediated endocytosis. There are different types of receptor mediated endocytosis. There are 4 different proteins which will help you in receptor mediated endocytosis. The proteins are clathrin, caveolin, megalin and cubilin. Receptor mediated endocytosis is helped by 4 proteins: clathrin, caveolin, megalin and cubilin. Megalin and cubilin are related to diseases. Megalin, this is helpful for endocytosis of albumin and hemoglobin. So any defects in megalin results in Donnai-Barrow syndrome. Not only albumin and hemoglobin, also insulin. Megalin is essential for endocytosis of albumin, hemoglobin and insulin. So any mutations of megalin results in Donnai-Barrow syndrome. Cubilin is essential for endocytosis of vitamin B12. Therefore, defect in cubilin results in what disease? B12 deficiency and megaloblastic anemia. So megalin is related to Donnai-Barrow syndrome and cubilin is related to megaloblastic anemia. So these are all the proteins which help in receptor mediated endocytosis. So that was about endocytosis. Now exocytosis. In exocytosis, there are 2 types: constitutive and non-constitutive. Constitutive means the substance is not processed inside the cell. Just like that, it is sent out. That is constitutive. Non-constitutive is the substance is processed inside the cell. What is it processing? It could be an inactive hormone. It's converted into an active form. Some processing happens and then it is vomited out of the cell. So if there is not processing, constitutive. If it is processed, then it is non-constitutive. These are the 2 types of exocytosis. What is transcytosis? Trans means across. How substances cross the cell. On one side, the substances are endocytosed. On the other side, it is exocytosed. It enters the cell through endocytosis and moves out of the cell through exocytosis. For example, maternal antibodies in breast milk. Maternal antibodies in breast milk. When the baby drinks breast milk, how does the antibody cross the intestinal cells of the baby and how does it reaches the baby's blood? This is called transcytosis. How does this happen? The maternal antibodies are endocytosed on one side. When the baby drinks this milk, milk goes into the intestine. Antibodies are endocytosed on one side in the intestine and they are exocytosed on the other side into the blood. This is called transcytosis. How they are endocytosed on one side and exocytosed on the other side. So different types of vesicular transport: endocytosis, exocytosis and transcytosis. What are the different types of fluids? Isotonic fluid, hypotonic fluid and hypertonic fluids. What is the meaning of iso? Iso means same. Any fluid which has same concentration as your plasma. What is the plasma concentration? 300. So any fluid which has 300 milliosmoles per liter is an isotonic fluid. Any fluid which has less than 300, hypotonic. More than 300, hypertonic. These are the different types of fluids. Examples. Example for isotonic fluid: 0.9% normal saline, 0.9% normal saline, lactated ringer solution, RL, 5% dextrose in water. All these are examples for isotonic fluids. When will you give isotonic fluids into a patient? What is isotonic fluid? Fluid which has same concentration as your body fluid. So whenever the patient is losing the body fluid, you can give him another fluid which has same concentration as his body fluid. So when will you lose your body fluid? Bleeding, like hemorrhage or vomiting, diarrhea, or any burns or trauma. In all these conditions, there is a tendency to lose fluid. When you lose your body fluid, you have to replace it with another fluid which has same concentration as your plasma. So in these conditions, we use isotonic fluids. Hypotonic fluid. Hypo means less than 300. 0.45 saline is hypotonic. When 0.9 saline is isotonic, half of that would be 0.45% saline. This is hypotonic. What is the indication for hypotonic? In hypernatremia. Hypernatremia means more sodium is called hypernatremia. Already the patient has more sodium inside the body. There are more salts already. He is in hypernatremia. And there is an indication for fluid transfer also. Now you can give him hypotonic fluid. Already his body is in hypernatremia. And if you want to give a fluid, you give a fluid which has less salts because already his body has more salts. So in hypernatremia, you give hypotonic fluids. Hypertonic. Hyper means more than 300. Any fluid which has more than 300 is hypertonic. If 0.9 saline is isotonic, any saline more than 0.9, 3% saline, 5% saline, all these are hypertonic. If 5 dextrose is isotonic, any dextrose more than 5, 10 dextrose will be hypertonic. So when will you give hypertonic fluids? If the patient has hyponatremia. Already his body has less salts, hyponatremia, and there is an indication for fluid also. Now you can give him a fluid which has more salts. If his body has less salts, you compensate by giving a fluid which has more salts. So in hyponatremia, you can prefer hypertonic fluids. These are the different types of body fluids. Based on this, we can draw a diagram called the Darrow-Yanet diagram. Mithilesh, types of exocytosis again please. Yes. In exocytosis, there are 3 types of exocytosis. So, what are you asking? Exocytosis. Okay. Sorry. 2 types of exocytosis: constitutive, non-constitutive. If the substance is not processed inside the cell, simply it is sent out, constitutive. If the substance is processed inside the cell, it is non-constitutive. What is that processing? It could be an inactive hormone. It is converted into an active hormone. Or it is a prohormone. It is processed into the actual hormone. Some processing will happen. After that it is exocytosed. This is called non-constitutive. Yes, what will happen when hypertonic solution given to hypernatremia? Doctor, if the patient has already more salts and you give him a hypertonic fluid, blood gets more and more concentrated, and that is going to affect the levels of ADH, aldosterone, all hormonal levels will be affected. So that is not correct for the patient. That is very dangerous. Blood cannot become very dilute, or blood cannot become very concentrated also. Then the viscosity will increase, blood flow itself will be affected. If the blood becomes more and more thicker, the blood flow is going to be affected. Okay, so over to this diagram. This is called the Darrow-Yanet diagram. How do we read this diagram first? So in this diagram, we have volume of ECF and ICF on x-axis, osmolarity of ECF and ICF on y-axis. volume in x-axis, concentration on y-axis. On osmolarity, we have osmolarity and volume of ICF and ECF. So what you see as the solid color, solid pink color is the ICF. It is more. Yes, it's 2/3. And this blue one is ECF. ECF is only 1/3. ICF is 2/3, whereas ECF is only 1/3. That's why the solid pink and solid blue. Pink is more and blue is less. And you can see a dotted line here. This dotted line represents the change. After your intervention or after the disease, the change in the graph is noted by the dotted line. Solid colors are the original conditions, actual ICF and ECF, and the dotted line indicates the change after the intervention or after the disease. How do we read this diagram now? There are 6 diagrams. This diagram itself is called as Darrow-Yanet diagram. Darrow-Yanet diagram. There are 6 diagrams, 3 gain of conditions and 3 loss of conditions. As you can see in this, gain of isotonic fluid, gain of hypotonic fluid, and gain of hypertonic fluid. 3 gain of conditions, loss of isotonic fluid, loss of hypotonic, and loss of hypertonic. 3 loss of conditions, 3 gain of conditions and 3 loss of conditions. Okay. First, when you read the diagram, I'll tell you a few rules to read the diagram first. You look only into the ECF changes, extracellular fluid. Don't look at the ICF at all, because ICF will make its change according to the ECF. Automatically it will make. Look only into the ECF changes, because any fluid you gain into the body or you lose from the body, it is going to be from the ECF only initially. Imagine I'm going to inject 1 liter of fluid into the body. If I inject 1 liter of fluid, where will this fluid go? It will initially go to the extracellular compartment. Yes, it will go into the blood. Blood is blood. Blood is ECF, extracellular fluid. So when you inject any fluid into the patient, it is first going to go into the ECF only. Or if the patient is bleeding or vomiting, he is losing his ECF fluid. So any loss of fluid or any gain of fluid is initially from the ECF only. That is why you look only in the ECF. Don't worry about the ICF at all. Because anyways, after equilibrium, ICF concentration will reach the ECF concentration. It will happen. So you don't worry about that. Look only in the ECF. Other rule is that if there is any isotonic solution, there is no change on y-axis. What is y-axis? Concentration axis. There is no change on the concentration axis, because if you infuse any isotonic fluid, for example, I inject 0.9 saline into the body. 0.9 saline has 300 milliosmol. Plasma also, blood also has 300 milliosmol. So if you give any fluid which has same concentration as the blood, the concentration of the body fluid will not change. So there is no change on y-axis. On the osmolarity axis, you will not see any change in the case of isotonic fluids. Or if you lose an isotonic fluid also, body concentration will not change. So the patient gains any isotonic fluid or loses any isotonic fluid, y-axis will not change, because y-axis is concentration or osmolarity. Any gain of condition, in any condition where the patient gains any fluid into the body, x-axis, what is x-axis? Look into the diagram. What is x-axis? X-axis is volume of ECF. So in any gain of fluid condition, x-axis will increase. Yes, volume will increase. Dotted line has gone out. Volume increases. So the x-axis, volume will increase in any gain of condition. The other rule is in any loss of condition. So there are 3 loss of conditions in the diagram. If the patient is losing any fluid in any loss of condition, ECF volume will decrease. So the dotted line will go inside. The dotted line will go in. Dotted line goes inside. Can you see? Dotted line has moved inside because volume has decreased. Dotted line has moved inside. So in any loss of conditions, volume decreases. Any gain of condition, in all these gain conditions, see the ECF volume has moved out. Volume increases in gain of condition, volume decreases in loss of condition. So these are all the basic rules. I'll repeat again. First rule, look only into the ECF. Second rule, if it is an isotonic fluid, no change on y-axis. Third is that any gain of condition, x-axis volume of ECF increases. In any loss of condition, x-axis volume of ECF decreases. And this diagram is called the Darrow-Yanet diagram. Let's read the actual conditions. First we will do gain of conditions. There are three conditions for gain of conditions. What are they? Gain of isotonic fluid, gain of hypotonic fluid, and gain of hypertonic fluid. Three gain of conditions. We'll read them one by one. The first one, any gain of isotonic fluid. What was the first rule? Isotonic means y-axis will not change. So look at the y-axis. Dotted lines and the solid line both are same. The dotted line, solid line, both are same. It does not increase, it does not decrease. So y-axis, no change. What is the example? Infusion of isotonic fluid. If I inject 0.9 saline into a patient, that is the gain of isotonic fluid. Since it's an isotonic fluid, y-axis, no change. But what will happen to x-axis? If you inject any isotonic fluid, any gain of fluid, what will happen to x-axis? Yes, volume will increase. So the volume increases. It is a gain of condition. So volume of ECF increases. It's a gain of isotonic fluid. So no change on the y-axis. Gain of means volume increases, isotonic. So there's no change on the y-axis. The second one, gain of hypotonic fluids. Example, 0.45 saline is hypotonic. Water intoxication, simply you drink more water. SIADH, syndrome of inappropriate ADH secretion. What is SIADH? A disease where you have excessive levels of antidiuretic hormone. What is the function of antidiuretic hormone? What is the role of ADH? Why it's called antidiuretic hormone? Diuresis means more water going out in urine. Then what is antidiuresis? More water goes into the blood. If more water goes out in urine, it is diuretic. If more water is not going out in urine and going into the blood, this is antidiuretic. So what is the function of antidiuretic hormone? Water reabsorption into the blood. So if there is more ADH, syndrome of inappropriate ADH secretion means there is so much of ADH. So there is so much of water reabsorption into the blood. If so much of water goes into the blood, what will happen to urine? If water goes into the blood, yes, there's less water only in urine. So the more of water has gone into the blood. If more water goes into the blood, ECF volume will increase. So that's why ECF volume has increased. On x-axis, volume has increased because more water has gone into the blood. This is a gain of condition. So what will happen to your body fluid concentration? If more water goes into your blood, it will get diluted. So y-axis has come down. See, y-axis from solid line, it has come down. Dotted line has moved down because ECF concentration decreases. If you add more water into your body, ECF concentration will decrease. Gain of hypertonic fluid. When there is gain of hypertonic fluid. Example, infusion of 3% saline, 5% saline, 10% dextrose, or you just take more of salt water. Anyway, there is a gain of fluid. In any gain of condition, ECF volume will increase. Yes, ECF volume has increased. It's a gain of hypertonic fluid. Hypertonic means you're taking in more salts into the body. What will happen to your body concentration if you take more salts? Body concentration increases. So when you gain any fluid, volume increases. Since you are gaining a more concentrated fluid, ECF concentration also will go up. See, the dotted line has gone up. ECF concentration also goes up. So this might look complicated when you do it all together, but if I show you only one diagram and I ask you the answer for one diagram, it will be easier for you. The same rule we will apply for loss of conditions also. The first one, loss of isotonic fluid. If you lose any fluid, what will happen to volume of ECF? Decreases. That's why dotted line has gone inside. Simple. If you lose an isotonic fluid, no change on the y-axis. So there's no change on the y-axis. Dotted line or solid line both are same. When will you lose isotonic fluid? Hemorrhage, vomiting, diarrhea. These are all examples for loss of isotonic fluid. Second one, loss of hypotonic fluid. Example, sweating. Actually, if you taste sweat, it will be salty. But when compared to blood concentration of 300, sweat has less salts only. So sweat is an example for hypotonic fluid only. Sweat is hypotonic. Although it tastes salty, it is an example for hypotonic fluid. So when you lose any fluid, whenever there is a loss of fluid, ECF volume will decrease. What is diabetes insipidus? Exactly the opposite of ADH is diabetes insipidus. Excessive ADH is called SIADH. Lack of ADH is called diabetes insipidus. So exactly they are opposite. So diabetes insipidus is ADH is not there. The function of ADH is water reabsorption into the blood. If ADH is not there, water is not reabsorbed into the blood. If water is not reabsorbed into the blood, where will it go? It goes out in urine. So there's plenty of water in urine. If more water goes out in urine, you are losing more water. So what will happen to the volume of ECF? It will decrease. Yes, when more water goes out in urine, ECF volume decreases. If water goes out of the body, what will happen to your body concentration? Water goes out, so body concentration will increase. That's why ECF concentration has gone up. Water has gone out. If water moves out of the body, inside concentration will increase. So ECF concentration has gone up. Dotted line has gone up. The last condition, loss of hypertonic fluid in Addison's disease. What is Addison's disease? Addison's is ADD. ADD means adrenal deficiency. ADD is adrenal deficiency. Deficiency of adrenal hormones. This is Addison's disease. Especially aldosterone. What is the function of aldosterone? Aldosterone helps in salt reabsorption into the blood. That is the role of aldosterone. But in adrenal deficiency, if aldosterone is not there, salt is not reabsorbed into the blood. If salt is not reabsorbed into the blood, more salt moves away in urine. See, anyway, it is a loss of fluid. Loss means ECF volume should decrease. So volume has decreased. But you are losing more salts in urine. If salt goes out of the body will get diluted. When water goes out, it is getting concentrated. If salt goes out of the body will get diluted. So more the salts go out in urine, ECF concentration will decrease. If salts go out, ECF concentration will decrease. So dotted line has come down. So this is how we read the Darrow-Yanet diagram. So you look at this all together, it is confusing. I can understand. Dr. Preeti, please explain hypotonic fluid of both gain and loss conditions. Yes, doctor, this is for you. Listen. Gain of hypotonic fluid means, first of all, you are gaining a fluid. Whenever you gain a fluid, ECF volume will increase. Yes. Hypotonic fluid means you are gaining a less concentrated fluid into the body. You are gaining a dilute fluid into the body. When will this happen? Infusion of 0.45 saline, because 0.45 saline is an example for hypotonic fluid. So when you infuse this, it's an example for hypotonic fluid. You just drink more water, body will get diluted. Or SIADH, syndrome of inappropriate ADH secretion. Inappropriately, so much of ADH is produced. If there is more ADH, the function of ADH is water reabsorption into the blood. If you have more ADH, more water will be reabsorbed into the blood. More the water is reabsorbed into the blood, see, water is added into the blood. So this water will dilute your body. Therefore, ACF concentration decreases. Because water is added into your body, ACF concentration will decrease. Loss of condition, loss of hypotonic fluid. Sweat is an example for hypotonic fluid, because when compared to 300 milliosmoles, your blood has 300 milliosmole. When compared to that, sweat has less salts only. So sweat is an example for hypotonic fluid. Diabetes insipidus. This is a condition where there is no ADH. The function of ADH is water reabsorption into the blood. But if ADH is not there, water is not reabsorbed into the blood. If water is not reabsorbed into the blood, where will it go? Into the urine. So if you lose more water in urine, it is a loss of condition. So ECF volume decreases, but you are losing more water in urine. If water goes out of your body, inside the body will become more and more concentrated. So ECF osmolarity increases. Volume decreases, but concentration increases. I think it was clear, Dr. Preeti. Yes. Okay, so I'll just give you some time. You go through all the 6 diagrams. I'll place it on the field only. Just look at all the 6 diagrams and go through it on yourself. Let's go to the other topic. What type of question is asked from this? Excellent, doctor. I just want to show you that. Yes, can you, this is the question that is asked from here. Can you guess the answer for this question, Dr. Vedashri? What is the answer for this question? Yeah, break time. We'll have break now. Just tell me the answer for this question. We'll finish this and we'll go for the break. Infusion of 1 liter of distilled water. What is distilled water? You take plain water, put it into the distillation machine. The machine will remove all the salts. It will give you only water. So water from which all salts are removed is called distilled water. So it is an example for hypotonic fluid. Distilled water is hypotonic fluid. Yes, think and answer. Distilled water is not isotonic, doctor. Distilled water is you take water, put it into the distillation machine. The machine will remove all the salts. It will give only water. Hypotonic. Now what is the answer? Yes. Okay. It's a gain of fluid. Good. It's a gain of fluid. First of all, it is a gain of fluid. So ECF volume increases, but it is increasing in all the three. It's an hypotonic fluid. If you give a less concentrated fluid into the body, body concentration also will decrease. So B would be the best option. Exactly. B would be the best option. So this is the type of question that can be asked from this topic. Excellent, all of you. B. Volume increases because you are gaining a fluid. It's a hypotonic fluid. So it is decreasing the concentration of your body. Yes. Other question. Can you try this? This diagram, Darrow-Yanet diagram. Look what has happened. ECF volume has increased, but concentration has decreased. It means some fluid has been added into the body, but it has diluted the body. So more water has been added into the body. In which disease more water will be added into the body? Yes, what is SIADH? When you have more ADH, more water is reabsorbed into the blood. More you reabsorb water into the blood, ECF volume will increase. This water will dilute your blood. So ECF concentration will decrease. Yes, the answer is SIADH. Excellent, SIADH. Good, 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 all of you. Excellent, doctor. Yes, gain of hypotonic fluid. This is the type of question that can be asked from here. Yes, 8 o'clock. Yes, it's another 1 hour session has gone. Okay, you want a break now? A small break? Because the class is till 9:30. Yes, let's have a small break, maybe 5 to 10 minutes of break, and then we'll continue with intercellular junctions. Yes, this is the special break slide for you. Sometimes when we think that we are fully prepared for the exam, see how the first question is striking you, in which small gap it is striking you. Yes, please have 10 minutes break. Thank you.